Welcome to the Public Health Practice Gap, the podcast where we bridge the distance between research, policy, and real-world practice. I am your host, Dr. Bradley Fevrier, public health educator, researcher, consultant, and founder of Next Gen Public Health Consultancy. Each week, we explore the science, the system, and the stories that shape health, not just healthcare. If your organization is looking for consulting, workforce development, or professional training, you can find that through Next Gen Public Health Consultancy at nextgenpublichealthconsultancy.com. Now, let's begin. Imagine two children born on the exact same day. Neither chooses where they are born, or the neighborhood they grew up in, or the quality of their local schools. Neither chooses whether there is lead in the drinking water, or whether the nearest grocery store sells fresh produce or mostly processed food. Neither chooses whether the nearest park is safe enough to play in after school, or whether the parents work one steady job or juggle three, or whether they grew up breathing clean air or air thick with pollution from a nearby highway. And yet, by the time these two children become adults, one may live 10, 15, or even 20 years longer than the other, not because one exercised more diligently or took better vitamins, but because the environments quietly surrounding each of them from the very first day of life shape thousands of decisions and thousands of biological processes over an entire lifetime. We admire discipline, hard work, and perseverance, and those qualities matter. But public health has taught us something equally important. Our environments matter too, and sometimes they matter even more than our choices do. Today's episode is about one of the most misunderstood ideas in health science, the social determinants of health. The name sounds technical. The concept is simple. Health is produced long before someone ever walks into a doctor's office. Last week, we talked about why you cannot biohack your way out of biology. Today, take the next step. If health is not completely determined by our personal habits, then what does determine it? When most people think about health, they picture hospitals, doctors, medicine, prescriptions. Those things matter enormously, but they account for only a portion of what makes populations healthy. Healthcare helps us after disease develops. Population health asks why the disease developed in the first place. Those are fundamentally different questions. Suppose two patients arrive at the emergency department with the same asthma attacks. A physician's job is to stabilize them, administer oxygen, provide medications, and prevent respiratory failure. A public health professional asks different questions. Why are asthma rates rising in that neighborhood? What are the children living there being exposed to? Is there poor housing with mold, industrial pollution or heavy truck traffic, indoor smoking, limited access to preventive care? Those questions move upstream, away from the emergency department and towards actual source of the problem. One of my favorite analogies for this comes from the public health pioneer Irving Zola. Imagine standing beside a fast-moving river. One person after another floats downstream, and you jump in to rescue them. Then another appears, and another, until you are exhausted and the current shows no sign of slowing. Finally, someone asks, who keeps throwing people into the river upstream? That question captures the entire difference between healthcare and public health. Healthcare rescues, public health investigates. Healthcare treats, public health prevents. Neither is more important than the other. We need both. Researchers have spent decades studying why some communities consistently experience better health than others, even with similar medical technology. Healthcare access alone did not explain the difference. Neither did genetics alone. So researchers broadened the view to education, income, employment stability, housing, transportation, neighborhood safety, food access, environmental quality, social support, early childhood experiences, and chronic stress. These factors repeatedly predicted health outcomes across countries, cultures, and generations, with a consistency that surprised even the researchers studying them. We call this collection of influences the social determinants of health. The World Health Organization defines them as the conditions in which people are born, grow, live, work, and age. Notice what is absent from this definition: prescriptions, supplements, wearable technology. None of those are unimportant, but they enter the story much later than most people assume. Health is built or undermined in homes, schools, neighborhoods, and workplaces, often long before anyone becomes a patient. This is not simply a theory. It is one of the most rigorously studied concepts in public health, one of the most influential studies in the Whitehall study, which began in the late 1960s among British civil servants who all had stable government employment and access to the same national healthcare system. Researchers discovered that health outcomes still differed significantly based on social position within the workplace. People in lower occupational grades experienced higher rates of illness and early mortality. The difference was tied to chronic stress, control over one's work environment, income, and social status. The study directly challenged the assumption that equal healthcare access alone erases health differences. It does not. The Framingham Health Study began in 1948 in Massachusetts, followed thousands of residents across generations, and identified the cardiovascular risk factors we now take for granted: high blood pressure, high cholesterol, smoking, inactivity, and obesity. These discoveries changed medicine and saved millions of lives. But there was a quieter lesson too. People do not develop health behaviors randomly. Smoking rates, diet, and stress exposures are shaped by the social and environmental conditions surrounding a person. Someone who works 2 jobs with unpredictable scheduling and has no safe space nearby for exercise experiences health very differently than someone with flexible hours and financial stability. Individual behavior matters, but behavior itself is shaped often long before a person is consciously aware of the forces shaping it. There is a phrase in public health: your zip code may be more important than your genetic code. Genetics matter, but where we live profoundly shapes the opportunities and risk around us. One neighborhood may have sidewalks, parks, affordable groceries, good schools, and reliable transportation. Another may have unsafe streets, limited grocery options, higher pollution, fewer recreational spaces, and chronic housing instability. Both may be full of people who want to be healthy, who care about their families, and who understand the importance of exercise and nutrition. But the daily reality in each place is fundamentally different, and the healthy choice is simply not equally available in both. We cannot simply tell people to make better choices without examining whether those choices are realistically accessible to them in the place where they actually live. The idea of longevity has captured enormous public attention, and the longevity industry has grown rapidly in response. People want to know the secret. What supplement, what technology, what routine will help them live longer than everyone else? But when researchers examine communities with unusually high rates of healthy living, the findings are far less glamorous and far more practical than the marketing suggests. Researchers studying so-called blue zones have identified common patterns. People move naturally throughout the day without needing a dedicated gym membership. They maintain strong social connections with family, friends, and neighbors. They carry a sense of purpose that extends well into old age. They eat mostly minimally processed foods, largely because that is simply what is available and normal where they live. Notice something? The secret is rarely a single dramatic intervention. It is an entire ecosystem working quietly over a lifetime. A person walks regularly because their community is designed for walking, not because they force themselves to hit a step count. A person eats healthier food because fresh food is genuinely available where they live, not because they are exercising extraordinary discipline against constant temptation. These are not isolated choices, they are systems. This brings us back to where we started. Modern wellness culture often focuses heavily on individual optimization. Track your sleep obsessively, measure every biomarker, buy the newest technology, follow the perfect diet. Many of these tools can be useful, and there is nothing wrong with wanting to improve your own health. The problem occurs when we mistake optimization for the foundation itself. A wearable device can measure your sleep with impressive precision. It cannot create the time in your schedule for you to sleep in the first place. A fitness tracker can count your steps accurately. It cannot build the safe sidewalks that make walking a realistic option in your neighborhood. Technology can support health. It cannot replace the systems that make health possible for entire populations in the first place. Before we continue, I want to thank the sponsor for today's episode, my new book, When Treatment Can No Longer Cure. It explores what happens when medicine reaches the limits of what it can accomplish, and the compassionate care, honest communication, and dignity that matters most in those moments. Whether you are a healthcare professional, a caregiver, or someone navigating serious illness alongside a loved one, I believe this book offers a genuinely important perspective. You can find it on Amazon, and remember, healthcare is not only about adding years to our life, it is also about adding humanity to years we have. So, let's get back to the show. Some people hear about the social determinants of health and assume public health is saying individual choices do not matter. That is not true. Your choices matter. What you eat, whether you exercise, whether you smoke, whether you manage your blood pressure, whether you seek preventive care. All of it influences your risk in measurable ways. But public health adds a critical dimension. The choices actually available to different people are not created equally. Someone with financial stability, predictable hours, and reliable transportation has a very different set of realistic choices than someone experiencing poverty, housing instability, or chronic stress. The scientific mistake, the one public health has worked for decades to correct, is assuming everyone starts from the same place. They do not, and pretending otherwise does not make it true. There is an important distinction between responsibility and blame. Responsibility asks, what can we do to improve health? Blame asks, who is at fault? Public health focuses on the first question because blame rarely produces solutions. Imagine telling someone with uncontrollable hypertension to simply eat healthier. That advice is not wrong, but it may be incomplete. Can they afford healthier food? Do they have time to prepare meals? Is healthy food available where they live? Are they working multiple jobs? Are they navigating chronic stress? That itself elevates blood pressure. The goal is not to remove accountability. It is to understand reality. Good public health does not lower expectation. It removes uncertainty. So, what could you personally do with all of this? The answer is not to give up. Individual action still matters. Move your body, prioritize sleep, eat nutritious foods, avoid tobacco, maintain relationships that matter most to you. Manage your stress as deliberately as you can. Stay connected to people and communities around you. But also, look beyond yourself. What policies would support healthier communities where you live? How can workplaces better support the health of their employees, rather than simply accommodating illness after it occurs? The future of public health depends on combining both approaches, individual empowerment and systems change. Both are necessary and neither alone is sufficient. This is why I created Next Gen Public Health Consultancy to help organizations, communities, and healthcare systems translate evidence into practice. The gap between knowing what works and actually implementing it remains one of the biggest challenges in public health. Closing that gap is the mission. If your organization is interested in consulting or training, visit nextgenpublichealthconsultancy.com. As we close, let us return to the question we started with. What determines our health? It is never just one thing. Not just genetics, not just lifestyle, not just healthcare, not just the environment. Health emerges from the interaction of all of these forces, working together, sometimes reinforcing one another and sometimes working in tension. Our biology matters. Our choices matter, our communities and policies matter, and sometimes, despite everything we do individually and collectively, uncertainty remains. This is not a failure of science. This is the reality of being human, living inside complex systems we can influence but never fully control. The goal of public health has never been to create a world where illness disappears completely. This was never a realistic goal. The actual goal is to create a world where more people have a genuine opportunity to live healthier, longer, and more meaningful lives, regardless of where they happen to be born. That requires compassion, it requires evidence, it requires action, and it requires understanding that health is never created alone, it is created together. Thank you for listening to the Public Health Practice Gap. I am Dr. Bradley Fevrier. If this episode helped you see health differently, please subscribe, leave a review, and share it with someone who would benefit from this conversation. Pick up a copy of my book, When Treatment Can No Longer Cure, and subscribe to the Next Gen Public Health Lab to continue the conversation. Until next time, improve the evidence, strengthen the system, close the gap.
Feet on the ground, but I still get by. The rules were made for someone else to try, but not me, not me.